Herpes zoster ophthalmicus. Symptoms: dermatome pain, paresthesia, and skin rash or discomfort. May be preceded by headaches, fever, malaise, blurred visions, eye pain, and red eye. Sign: critical, acute vesicular dermatomal skin rash along the first division of the fifth cranial nerve. Characteristically, the rash is unilateral, respects the midline, and does not involve the lower eyelid. Hutchinson signs: tip of the nose involved in the distribution of the nasociliary branch of V1, predicts higher risk of ocular involvement. Treatment, workup. History: duration of rash and pain, immunocompromised or risk factors for HIV or AIDS, hearing changes, facial pain or weaknesses, vertigo, rashes elsewhere. 2. Complete ocular examination, including a slit lamp evaluations with fluorescein or rose bingo staining, IOP check, and dilated fundus examination with careful exam for progressive outer retinal necrosis and immunodeficiency related manifestation of VZV. 3. Systemic evaluations. Patients less than 40 years consider medical evaluations for immunocompromise status, particularly HIV. Patients aged 40 to 60 years, none, unless immunodeficiency is suspected from the history. Patients greater than 60 years, if systemic steroid therapy is to be instituted, obtain a steroid workup as required. Treatment. See Table 4.16.1 for the treatment of VZV in immunocompromised patients. Drugs: acyclovir, 10 milligrams IV toxicity, intravenous, reversible renal and neurological toxicity. Contraindication: used with caution in patients with a history of renal impairment. Alright, so this is more oral medications. Follow-up. If ocular involvement is present, examine the patient every 1 to 7 days, depending on the severity. Patients without ocular involvement can be followed every 1 to 4 weeks. After the acute episode is resolved, check the patients every 3 to 6 months.